Good afternoon. Today's lecture is by Dr. Koyal Shanbag, who will be speaking on long wave diathermy. Dr. Koyal has completed her Bachelor's of Physiotherapy and Master's of Physiotherapy in Pediatrics from SDM College of Physiotherapy. She has also completed her Aquatic Therapy Foundation course from ATNI. Before we start the session, I request everyone to mute their mics to avoid any disturbance, and please save your questions till the end. Over to you, Dr. Koyal.
Thank you so much, Joshien. Sorry if I'm saying it wrong, for introducing me. So today's good afternoon, everybody. Today's topic is long wave diathermy. I hope everyone is able to hear me.
Yes, Koyal, you are audible.
Yes. So, as the name says, long wave diathermy. This is the machine that we have seen in our clinic and we have been using it. As the name says, long wave diathermy means there is a long electromagnetic waves that we use, usually of 1 megahertz, to produce a deep heating which usually goes to 1 to 3 centimeters or even 4 centimeters inside and gives us a pain relief and tissue healing. So the mechanism of action is that these electromagnetic waves that are produced, they penetrate inside the tissue, they cause molecular vibrations and generate heat within deep tissue. So this all causes vasodilatation, that is increased blood supply, which eventually increases the oxygen and nutrition supply to the part. And this takes away the waste products and eventually gives us muscle relaxation. This helps in accelerating the healing. So it's an adjunct used in our therapy. Let's see the neurophysiology of this modality. It usually works on, it stimulates the thermoreceptors present on the skin, and this works via the gate control theory, pain gate control theory. So this increases nerve conduction velocity and muscle relaxation. Let me just brief you about the gate control theory. So we all have these nerves that go from the various parts of our body through the spinal cord to the brain. So in the nerves, there are two types of nerves, the large, which are usually the myelinated nerves, and the small nerve fibers that are non-myelinated or semi-myelinated nerves. Okay, so the large nerve fibers, they carry sensations like vibration, touch and proprioception. And the small nerve fibers, they carry sensations like pain and temperature. They even help in sending autonomic signals to the internal organs. So whenever there is any stimulus and we are trying to heal it, so there is a competition that happens between the large nerve fibers and the small nerve fibers. Eventually, because they are large, they are well myelinated. That is why these are the alpha A beta fibers. The large fibers, nerve fibers, are A beta fibers, and the small nerve fibers are A delta and C fibers. So there is this competition happening, and the large nerve fibers send the signals faster. So whenever we have pain, we see that we touch, we put pressure. This is all carried by the large nerve fibers, and that is why there is a closure of the gate that happens at the substantia gelatinosa in the dorsal horn of the spinal cord, and thus that signal is sent faster. So this entire modality that is used works on this mechanism. That is the pain gate control theory. Let's see what is this machine about and how do we use it. So it's very common, it is commonly used in clinic setup. It is slightly difficult to carry it at the homes. and it's user friendly, it's adjustable, it has adjustable intensity and time, and it's safe. So the first thing we should remember is the patient positioning, electrode placement, and selection of the parameters, etc. So we'll see how it works. This is a video by the makers of this machine, so the company itself. Yeah. We'll just fast forward it. This is a machine and it has 3 applicators. One is large, one is medium, and one is small. You'll see this. We have been seeing in our clinic. Then these are the applicators. These are the 2 electrodes that are given. One is a flat one, and one is which can be held in the hand. These are the mostly inactive electrodes. The active one is through which the emission of current passes, and that is through the applicator. And there is a gel that is given. This is a specific type of gel, and it should be used only with this machine. Also, we are first supposed to see if it is connected. There is a switch behind, and then the power button that is there. Just on it. Then we get these 2 modes, continuous and pulse. So this machine has a capacitor mode. It doesn't have the resistive mode. So what's the difference between capacitor and resistive mode? The capacitor mode targets only the superficial soft tissues like muscles and fat, whereas the resistive mode which is there that focuses on the deeper tissues, like it goes up to the bone, the ligaments and other structures with it. So this machine is only made it only has the capacitor mode. It doesn't have they are working on the resistive mode. So the capacitor mode has 2 modes in it. One is continuous and one is pulse. We can select continuous is mostly given to those with chronic cases, 3 months and above pain, etc. And pulsed is given in those who have pain acutely or in subacute conditions, and later on we can move to continuous. So it's a very easy to use machine. Also, it will give us the intensity and time. Intensity depends on how much warmth the patient requires. It is up to their tolerance. And time is it can even go from anywhere between 10 minutes to 30 minutes depending on the condition time. So this is how we are supposed to hold it in the hand and see to it that there are no metal implants or no metals present in the hand. And if we are attaching it to this flat electrode, it has to be covered by this lint pad and soaked it in water for better circuit conduction. And the applicators that are there, the 3 applicators, that depends on the size of the area that is required to be covered. Smaller area we can use this smaller applicator. And see to it that you nicely press it. You don't have to put on a lot of force because that is how you are supposed to maintain the machine. Yeah, this is how we usually give the application, mostly in circular manner or figure of 8 manner. So let's see when to give the continuous mode and pulse mode. The continuous mode gives a thermal effect, as in it will give out heat. In pulse mode, it will not give out heat. It will give out the electromagnetic waves in a burst forms, on and off cycles. So that is why we need to use it in the acute cases, and for continuous mode, we need to use it in the chronic cases. Let's see the effect of tissues. The continuous mode produces significant deep heating, vasodilatation, increased blood flow, and tissue extensibility, whereas the pulsed mode gives more cellular physiological effects, promotes healing without overbearing. The clinical effects. The continuous mode will give out pain relief, muscle relaxation, and reduce joint stiffness. And the pulse mode reduces inflammation, enhances tissue repair, safe in subacute cases. So the pulse mode is usually given in inflammation. If there is inflammation, there is post-injury healing, ligament sprains, tendinitis, etc. in the early stages. Whereas the continuous mode is given to chronic conditions, osteoarthritis, muscle tightness, joint stiffness, and given in examples like OA knee, chronic low back, etc. These are the indications: low back pain, cervical spondylosis. You can even give it in osteoarthritis, muscle spasms, joint stiffness, tendinitis, versus any soft tissue injuries and sports injuries, frozen shoulders, etc. Contraindication. The major contraindication is pacemaker or any implanted electronic devices. It cannot be given in pregnancy, malignancy, active infection, open wounds, and of course metal implants. What are the advantages of this machine? One is that it gives on deep penetration to than any other superficial modalities. It is very comfortable for the patient, and it covers a larger area as compared to ultrasound and even SWs. It's much safer also than SWs. The limitations are it's not suitable for acute inflammation. It is less precise targeting compared to ultrasound, and risk of burns is there because it gives out heat, and requires trained handling. Equipment cost is also higher as compared to other machines, and it cannot be used near the metal implants. So how will we decide whether we should go for continuous or pulsed mode? So we should first see whether the patient has inflammation, whether they have swelling, redness, warm. These are all signs of acute cases, and if it is there, then we should first go for pulsed mode, where it is a non-thermal effect. If the condition is chronic, which is more than 3 weeks old, we can use continuous mode for this. If it is not, then we are still supposed to be considering it as a subacute stage, wherein we can start with pulsed and progress to lower continuous and then continuous. If also, we should ask for patients' feedback. If they feel that is too much heat, we can go switch on to pulse mode. So what are the steps that we have to do while using long wave diathermy? One is ensure that the machine is plugged in, and patient positioning is the next thing. See that the patient is comfortable. If there is any metals on the area to be treated, we are supposed to remove it. Then apply the gel applicator in a proper manner, generous layer. And this is for this is a conductive gel. It will ensure that the electromagnetic waves penetrate deep inside. And then we are supposed to select the applicator depending on the area. Safety, see to it that the probe is in contact with the skin all the time to complete the circuit. We are of course not supposed to drop it, because then it can cause any problem to the machine. And contraindications, we are supposed to see what contraindications are there in the patient and likewise use the specific modalities. Let's see the technique of using this machine. First, ensure that the inactive electrode is held nicely in the hand, or if we are going for the flat electrode, we should see to it that it is in contact with the skin to avoid any superficial burns. Then we have to constantly keep the probe in motion. This is a major thing that has to be done, because even if we keep it slightly in a static manner, there is chances of feeling too much heat and eventually burn. And we are always supposed to move it in a slow, rhythmic, circular figure of 8 pattern. That we can even do it in a longitudinal or vertical manner on the scale. Then the stroke should be overlapping. This each circle should overlap the previous one by about 50% to ensure uniform heating across the entire target area. This is very important. And the speed should be roughly 1 to 2 inches per second. So if we move too fast, it will prevent deep heating, and if we move slow, there are chances of burns or hot spots. This is a small how to use the applicator in a circular fashion. See how they move it in 1 to 2 inches per second. Yeah, we should ensure that there is flat contact and there is no tilting of the probe, because then the energy concentration will be on that area which is in contact. So this can cause a sharp and stinging pain. Light to medium pressure has to be applied to maintain seal with the conductive gel. We cannot push it too hard so that the gel will spread away. We should move it in a comfortable pressure. Then we should always see to it that the movement happens from the most painful area to spreading it around. So it should go from the center to the periphery in the targeted area. If there is a bony prominence, if we wish to give long wave diathermy in a bony prominence, we should see to it that there is movement that is happening slightly faster than we usually do it on the muscular area. Because bone, there is direct contact of skin to the bone. There are no muscles over there. So there are chances of heating up more present. And if we feel we are running dry, we should apply more gel to avoid gap between the probe and the skin, to avoid all those pricking kind of sensations. Okay. What is the difference between long wave diathermy and short wave diathermy? So long wave diathermy gives out electromagnetic waves around 1 megahertz, whereas short wave is 27.12 megahertz, which is a lot, and that is the reason why it is not used in the Western countries. Still using it in India, but we ideally are not supposed to use short wave diathermy, or if we use it is with lot of caution, because the heat that is generated is too much. Also, the depth is in the long wave diathermies are in moderate to deep, whereas in short waves they are very deep. The heat control is more controlled in the long wave, and it can be intense in the short wave diathermy. And usage of long wave diathermy is more safer and more advanced as compared to short wave diathermy. Let's see about the evidence-based practices. Mostly the evidences say that it gives a moderate evidence for pain relief. It's useful as an adjunct therapy. We cannot rely fully on long wave diathermy, and we should always use it with exercise or other modalities. And combination with manual therapy will give out the best outcomes. So there was a literature review on effects of long wave diathermy in subjects with musculoskeletal pain by Mahima et al. There were lots of literature studies that were collected from PubMed, Google Scholar, Science Direct for studies in between 2006 to 2024. And focusing on randomized controlled trials, cohort studies, and systematic reviews on long wave diathermy for muscular pain. The outcome assessed was pain intensity, muscle relaxation, range of motion, functional results. Studies not related to musculoskeletal pain using different diathermy types were also excluded. And this shows the conclusion was that the result was that it effectively reduced pain and enhanced mobility in individuals with conditions like osteoarthritis and tendinopathy. But the long-wave diathermy can reduce pain. It can improve the functions, no doubt. But the comparative efficacy of LWD against any other treatment is unclear and indicates a need for more high-quality studies to define guidelines and optimums. There was another study that was conducted to compare the immediate effect of long-wave diathermy versus ultrasound therapy for pain and dysfunction in upper trapezitis in college-going students. Upper trapezitis is very common, and so the method was 60 students were taken, 30 students in each group, and group A received long-wave diathermy with trapezius muscle stretching, and group B received ultrasound therapy with trapezius muscle stretching. And the outcome measure that was used was numerical pain rating scale, neck disability index, and cervical range of motion were measured immediately pre and post. So statistical analysis and results showed that the immediate effect of LWD was found to be effective in improving cervical side flexion range of motion as compared to immediate effect of ultrasound. But the conclusion is that there were no significant result noted on reducing pain and functional dysfunction while comparing LWD versus ultrasound. So both gave a similar effect. So it's on us to choose the modality. Let's see a case study analyzing the effects of long-wave diathermy on quality of life among patients with knee osteoarthritis, a pilot study. The aim was to compare the effects of pulsed long-wave diathermy and continuous long-wave diathermy in quality of life in individuals with knee osteoarthritis while using the WHO quality of life and VRF. There were 30 participants above age of 45 with grade 2 and grade 3 OA and were randomly assigned to pulsed and continuous long-wave diathermy group. Both received conventional therapy for 8 weeks, 3 sessions per week. Quality of life was assessed at baseline before treatment and at 4 weeks and 8 weeks using the Mann-Whitney U test, and repeated measures ANOVA were used for analysis. The conclusion was that continuous long-wave diathermy combined with conventional therapy is more effective than pulsed long-wave diathermy in improving quality of life in individuals with OA. Further large-scale studies are still recommended. So we can use continuous long-wave diathermy in long-term OA patients. There is one more therapy, that is TCAR therapy, that is now in the market, and wanted to see whether long-wave diathermy and TCAR therapy, the comparison between both of them. So what is TCAR therapy? The TCAR therapy is generally considered superior to traditional long-wave diathermy due to its superior versatility, allowing both non-thermal, that is acute and chronic settings, as well as its ability to be combined with active rehabilitation. While both use radio frequency to heat deep tissues, TCAR provides faster pain relief, deeper and more targeted and more comfortable energy transfer. So there are 4 things that we can compare it with. TCAR, one is the technology. The TCAR has more advanced diathermy as that uses it can use both the capacitive and resistive mode. So as we know, this machine that we have usually uses the capacitive mode, and the TCAR is best in it's highly effective for both acute and chronic musculoskeletal injuries, sports rehab, and muscular injuries. LWD is commonly used for chronic pain or myofascial pain and arthritis. versatility, TCAR is more versatile, can be tailored to the patient's condition, and it can be used along with manual therapy. And as if we compare comfort, then both are comfortable. Just that the TCAR provides a more deeper sensation as compared to the long wave diathermy. But TCAR is the new trend that is coming as compared to the diathermies that are. These were the references. Thank you for your attention.
Thank you, Dr. Koyal, for that insightful lecture. Does anyone have any questions?
Hi, good afternoon. Great job, Dr. Koyal. You've covered LWD very well, all the basic points. I have just a food for thought. The last spoke about laser, the class 3 laser, and how it has an effect on mitochondria. Correct? Hello? Can you hear me?
Yes, ma'am.
Yeah, Azmat, can you just recap of how laser therapy affects mitochondria?
So, ma'am, when there is the application of laser light onto the skin, there is absorption of the chromophores which are present in the mitochondria. They absorb the laser light.
Okay, and what happens to the mitochondria?
And then then it helps into the deeper penetration, the laser lights, and then it decreases inflammation, it increases the tissue healing and the cell regeneration.
Okay, so I'll just so mitochondria is the powerhouse of a cell. Okay, mitochondria is the powerhouse of the cell. It is where energy is used, toxins are produced. A healthy mitochondria means a healthy cell. So, if we look at it this way and we consider a combination therapy, it would be a good research topic. If we consider combination therapy where laser is given for the mitochondria and LWE is given to improve the blood supply to help better oxygenated blood reach the mitochondria and allow removal of the toxins in the mitochondria, the cell becomes healthier. Yes?
Yes,
Hello?
ma'am.
Yeah. So it would be a great thing for us to try out clinically whether we can use laser therapy and LWD as a combination when we are working with patients who are having muscular pains, spasms, injuries, correct? So we can think about trying this out because given the theory behind both the machines, it makes a lot of sense for us to try it out. Maybe there is some research we can just check upon it already done. And we can think about using laser and LWD as a combination therapy or TCAR therapy, whichever. But since we are talking about LWD, we can think about using it as a combination therapy. Okay. Great job, Koyal. And you've covered all the topics, right from the theory behind it, its applications, indications, contraindications, comparative studies done, proving its effectiveness. At the end of the day, all this, whether it is our laser, whether it is our LWD, whether it is our IFT machines, they are machines to help us do our job better, to get a better result. But at the end of the day, nothing can replace exercise therapy. So, remember, as a physiotherapist, our main thing is exercise therapy. But we have a lot of tools like these equipments to help us do our job better. Yeah, I'll pass it on to the next person.
Yes, ma'am.
Does anyone else have any other questions? With this, we conclude the meeting. Thank you, Dr. Koyal.
Thank you so much. Thank you, everyone.